Thank you very much, and thank you for the kind introduction. I'd like to thank the organizers for the opportunity to participate in this meeting and our distinguished chairman as well. So this morning we talked a bit about improved monitoring strategies to keep patients out of the hospital. This afternoon we're going to talk about how to take care of patients once they're admitted to the hospital with acutely decompensated heart failure. I think you're all aware of the epidemiological importance of acute decompensated heart failure, the most common cause of hospitalization in the elderly population, associated with the highest 30-day rate of readmission of any medical or surgical cause of hospitalization in adults. So let's take a look at how we approach acute decompensated heart failure. First of all, it's important to note that no evidence-based guidelines exist for the management of acute decompensated heart failure. Our heart failure guidelines address ADHF, but the recommendations are based on consensus. We really are lacking good large-scale randomized controlled trials, and I'll underscore that in a moment. The effects of traditional or standard therapies, including intravenous diuretics, nitrates, dobutamine, and Milrinone, on outcomes have never been evaluated. These agents may be referred to as standard therapies simply because they came along before some of our newer treatments. In this regard, few large-scale randomized controlled trials have prospectively evaluated the effects of ADHF treatments on outcomes, and none have demonstrated improved outcomes. Analysis of some trials has raised concern about the safety of certain agents or drug classes, and better clinical trials and better therapies are needed to treat acute decompensated heart failure. So let's talk about the goals of ADHF treatment, remembering that most patients, 9 out of 10 patients admitted to the hospital with ADHF, are wet. They have volume overload or extracellular fluid volume excess. So we want to alleviate their symptoms, particularly their congestive symptoms, shortness of breath, pulmonary and peripheral edema. We do this in part by reducing extracellular fluid volume excess. We want to improve their hemodynamics, particularly by lowering left and right ventricular filling pressures, and perhaps improving cardiac output, although the totality of evidence suggests that patients are made better primarily by reducing their filling pressures unless their cardiac outputs are particularly low, and we want to maintain perfusion to vital organs. So how do we accomplish these goals? Unlike the treatment of chronic heart failure, which is anchored on the use of neurohormonal inhibitors and antagonists, the treatment of acutely decompensated heart failure has focused primarily on hemodynamic interventions, including diuretics, nitrovasodilators, natriuretic peptides, positive inotropic agents, including the 3 classes of agents shown on this slide, and in extreme cases, as a heroic measure, mechanical interventions that improve hemodynamics, such as an intra-aortic balloon pump or a ventricular assist device. Well, here is our basic approach, our pharmacological approach to treating acutely decompensated heart failure. We use diuretics to reduce extracellular fluid volume excess, generally beginning with an intravenous loop diuretic and sometimes adding a second agent. We also might employ intravenous vasodilators to reduce ventricular filling pressures or intravenous positive inotropic agents to improve cardiac output. So let's take a look at some of these strategies, and in particular, I want to highlight some of the frustrations that are seen in the management of acutely decompensated heart failure and emphasize the need for the development of newer and better therapies for this disorder. The administration of IV loop diuretics is currently the mainstay of treatment for ADHF. Dosing has never been rigorously evaluated except in one recent pilot study called the DOSE trial, which was published a few weeks ago in the New England Journal of Medicine. That study suggested that there was little difference between high dose versus low dose diuretic strategies and between bolus administration versus continuous administration of diuretics. But please remember that this was about a 200 patient study, so its results may not be considered definitive. Synergy may be seen with the combined use of loop and thiazide type diuretics, and limitations of available diuretic therapies may worsen outcome in some patients. And this represents the two-edged sword of diuretic therapy in the treatment of heart failure. So the limitations of diuretic therapy include electrolyte abnormalities. Generally, we can manage those relatively easily with electrolyte repletion or free water restriction. But tougher to manage is the decrease in glomerular filtration rate that may occur in association with the use of IV diuretics for the treatment of acutely decompensated heart failure. Many patients experience worsening renal function, the development or worsening of prerenal azotemia, and the development or worsening of diuretic resistance, or the so-called cardio-renal syndrome, in the setting of diuretic therapy for ADHF. These data come from Steve Gottlieb at the University of Maryland and demonstrate the effect of a single intravenous bolus dose of furosemide on glomerular filtration rate in patients with advanced heart failure, showing a nearly 20 ml per minute reduction in the GFR following administration of the loop diuretic. So this is part of the defeating cycle of diuretic use in the setting of acute decompensated heart failure. Yes, we may initially get some increase in urine output, but this is often at the cost of renal function. And as I'll show you in a moment, this may worsen patient outcomes. So in this study from Javed Butler and colleagues, looking at the association between worsening renal function during treatment of acute decompensated heart failure and patient outcomes, worsening renal function, which was defined as an increase in serum creatinine of just 0.3 milligram per deciliter, occurs in approximately 30% of ADHF patients. Nearly 1/3 of our patients in the hospital being treated with diuretics for ADHF experience worsening renal function. These patients have a 6-fold higher risk of in-hospital mortality and a greater than 3-fold higher risk of prolonged hospitalization. The use of higher loop diuretic doses are associated with worsening renal function. However, in this study, the use of higher loop diuretic doses was not associated with increased diuresis. So this and other studies like it have led us to the proposal of the iatrogenic cardio-renal syndrome of heart failure, where our current approach to treating heart failure with intravenous loop diuretics may actually worsen the disorder and worsen patient outcomes. Here you can see that diuretic therapy may lead to worsening of neurohormonal activation, a decrease in blood flow, and a decrease in renal perfusion. This in turn results in an impairment or further impairment in renal function, the development of diuretic resistance, and increased morbidity and mortality in these patients. So in these types of patients, what is the alternative to diuretic therapy? Well, it may be ultrafiltration. And I say maybe because I think we need additional data to support broader use of ultrafiltration in the setting of acutely decompensated heart failure. But we do have some data that supports its use, and I'll tell you how we use it at our center. This particular device is a simple to use device which may use peripheral venous access. The total amount of blood that is outside of the circulation in the ultrafiltration circuit is only 33 ml. So the risks, particularly the incidence of hypotension associated with this approach to ultrafiltration, rather than an approach more like dialysis, is very low. We see very little adverse events or hypotension. You can take a lot of fluid out as much as 500 mLs of fluid per hour. And this is highly automated system, and it's used at our institution on our cardiology wards under the supervision of cardiologists. You don't need a dialysis technician or a nephrologist to manage this particular approach to ultrafiltration. Now, in the most substantial trial performed to date using this approach, the UNLOAD study, which was led by Maria Rosa Costanza and colleagues, ultrafiltration in ADHF was shown to be safe. It effectively removed more fluid than with diuretic therapy, the primary endpoint of this study, but there was also a signal for improved outcome over 90 days post-discharge. There was a fewer number of patients rehospitalized in the ultrafiltration arm, a fewer number of rehospitalizations, and fewer days rehospitalized in those patients treated with ultrafiltration as compared to those treated with traditional diuretic therapy. At The Ohio State University, at the present time, we use ultrafiltration in patients who demonstrate diuretic resistance. We just can't diurese them adequately. And in those patients who we define as having gross volume overload, these are patients that present with 10 or 20 or 30 pounds of fluid excess. Because with ultrafiltration, we're able to remove 2, 3, 4, 5 liters of net fluid a day compared to maybe 1 or 2 liters with diuretic therapy with the same degree of safety or renal safety in these patients. We perform this under the direction of a cardiologist or a nephrologist, again in our heart hospital or on our heart services under the direction of the cardiologist. We use peripheral or central access, and we use routine anticoagulation so these systems don't clot. The treatment protocol includes continuous treatment until the patient achieves clinical treatment goals of compensated congestive heart failure. We retreat patients who relapse, and the filters are good for up to 72 hours unless they clot. Now let me just say a few words about positive inotropic agents. These agents are listed on this slide. Levosimendan is not available in the US, but I believe it's available here. It's available in some places outside of the US. In terms of a rational approach to selecting a positive inotropic agent to use in heart failure, we can make this decision based on various patient subsets. For example, the hypotensive patient might do better with a pure inotrope like dobutamine rather than an inodilator like Milrinone, which may be associated with a higher risk of hypotension. On the other hand, the patient who has concomitant pulmonary hypertension might do better with the phosphodiesterase inhibitor, which is a good pulmonary vasodilator, compared to the sympathomomimetic agent, which is a poor pulmonary artery vasodilator. Unfortunately, there are many limitations of positive inotropic agents, and this has been one of the holy grails of acute decompensated heart failure, trying to find a positive inotropic agent that doesn't worsen outcome. These agents are associated with the development of tolerance and tachyphylaxis, with hypotension and tachycardia, but most importantly with arrhythmias, including atrial fibrillation and flutter, and life-threatening ventricular arrhythmias. And there is evidence that suggests that while we might benefit patients on the short term with the use of a positive inotropic agent, in the long run, we may actually increase mortality. Here's an example of some of the data. This comes from the Optime CHF trial, a randomized placebo-controlled trial of Milrinone in the treatment of acute decompensated heart failure that demonstrated that Milrinone worsened all outcomes. There were more treatment failures, more hypotension, more acute MIs, more atrial fibrillation, and while statistically insignificant, there was a trend towards an approximate 1.5-fold increase in all-cause mortality. That's not the only inotrope study that shows that. There are many, many others, and I'll just show you another example from the Levosimendan experience. We had high hopes that this drug would not result in a worsening of outcome, but here, if one looks at the Revive 1 and Revive 2 trials, placebo-controlled trials of Levosimendan, you can see that at every follow-up time point, 5, 14, 31, and 90 days, there's more mortality in patients randomized to Levosimendan than there are to patients randomized to placebo. Well, finally, let me close with a brief discussion of vasodilators. The three agents that are used predominantly are nitroglycerin, nitroprusside, and the synthetic form of human B-type natriuretic peptide or naseritide. You can see on this slide some of the comparative hemodynamic effects of these agents. They too have limitations. The nitrovasodilators in particular are associated with the development of tolerance, and nitroprusside with thiocyanate or cyanide toxicity. There are also studies, for example, from Packer and colleagues from the 1980s, which demonstrate worsening vasoconstrictor activation and fluid retention during the continuous infusion of nitroglycerin. The natriuretic peptides have been proposed as alternatives to the nitrovasodilators in the treatment of acute decompensated heart failure, and the VMAC trial demonstrated the superiority of naseritide versus placebo or the active control nitroglycerin in reducing the pulmonary capillary wedge pressure. However, subsequent to FDA approval of naseritide, questions were raised about its safety. And very recently, as of last November, in a late-breaking clinical trial presentation at the AHA, we learned the results of the Ascend-HF trial, a landmark trial that was designed to evaluate the safety of naseritide in the treatment of acute decompensated heart failure. This is an impressive study in that it is the largest randomized controlled trial of ADHF ever performed, more than 7,000 patients. The results clearly demonstrate the safety of natriuretic peptides in the treatment of ADHF, and they unambiguously put to rest the critical questions raised by the meta-analyses published in 2005, raising concerns about the safety of naseritide. However, this trial raised newer questions about the efficacy of this approach to treating ADHF because the primary endpoint, which was relief of dyspnea, was not statistically met in the Ascend-HF trial. Here are the safety results of the Ascend-HF trial demonstrating no difference between placebo or standard of care and naseritide in terms of 30-day death or heart failure rehospitalization, 30-day mortality alone or heart failure rehospitalization. If anything, the trends slightly favor naseritide, but statistically, these are no different. So we now know that this is a safe agent, but again, its efficacy or deciding which is the right patient to use this in is a bit in question. So as I mentioned, we need newer therapies, we need better therapies for the treatment of ADHF. The hunt goes on. There are many compounds that are in preclinical or in clinical study. Ularitide, which is a second generation, more renal specific natriuretic peptide. CDNP, which is a natriuretic peptide that was created in the laboratory of John Burnett, combining bits and pieces of multiple endogenous natriuretic peptides. Relaxin, which is now being evaluated in a phase 3 pivotal trial. Nitroxyl donors, vasopressin antagonists, and a growing list of many other agents. So where does that leave us in 2011? This is my simple view of how to approach patients with acutely decompensated heart failure, focusing on those, the majority of patients admitted with volume overload. So we start with the patient with clinical congestion, and the next step is to assess the adequacy of their peripheral perfusion. We can do that clinically, or we can do that by assessing their hemodynamics. In the patient who is wet and truly warm, who has adequate peripheral perfusion or a preserved cardiac output, an IV diuretic is generally enough to treat that patient, acknowledging the fact that some patients may develop worsening renal function in the setting of IV diuretic therapy. At the other end of the spectrum, the patient who's in cardiogenic shock, this is the patient who's cold, hypotensive, has a narrow pulse pressure. If you place a Swan-Ganz catheter, their cardiac index is very low. for example, less than 1.5. These patients need an IV diuretic because they're wet, but they also need immediate stabilization of their blood pressure, immediate improvement in vital organ perfusion. They need a pressor agent or an inotrope, even though there may be some risk for increased mortality. But the largest group of patients admitted to the hospital with ADHF fall in between. These are the patients that I would describe as being wet and lukewarm. They have a reduced cardiac output, but they're not yet in cardiogenic shock. And these patients are well suited to treatment with an IV diuretic plus an IV vasodilator, such as a nitrate or natriuretic peptide. Thank you for your attention.